Hello, everyone. Welcome to The Open Mind, a lecture and film series that brings together thought leaders at the intersection of science and culture for meaningful and relevant programs about mental health. This series is proudly sponsored by UCLA's Friends of the Semel Institute for Neuroscience and Human Behavior and the Resnick Neuropsychiatric Hospital Board of Advisors. My name is Vicki Goodman, and today it is my honor to welcome and introduce two distinguished scientists, Dr. Jessi Gold and Dr. Helena Hansen, who happen to have a great deal in common. Both are psychiatrists, both are anthropologists and authors, and both went to the Yale School of Medicine. It's exciting to have these two accomplished women with us here today for what promises to be a very lively and interesting discussion about the search for humanity in medicine. I'm thrilled to welcome back to the Open Mind Dr. Jessi Gold, who, if you happen to tune into our Teen Advisory Council's Open Mind on stress and college admissions, was one of the panelists in her capacity as the Chief Wellness Officer for the University of Tennessee, that has 5 campuses across the state that includes 59,000 students and 19,000 faculty and staff. Dr. Gold is the author of the new book that just launched last week and already is a national bestseller, How Do You Feel? One Doctor's Search for Humanity in Medicine. Dr. Gold is the Associate Professor of Psychiatry at the University of Tennessee Health Science Center. She also works clinically as an outpatient psychiatrist at Student Health. She writes and is a regular expert in the media on mental health and is also a social media influencer. She has been featured in, among others, the New York Times, The Atlantic, NPR, PBS NewsHour, The Washington Post, and Self. She is a graduate of the University of Pennsylvania, with a BA and MS in anthropology, Yale School of Medicine, and Stanford University Department of Psychiatry, where she served as chief resident. Dr. Helena Hansen is professor and interim chair of the Department of Psychiatry and Biobehavioral Sciences at UCLA's David Geffen School of Medicine, and the interim director of the Semel Institute for Neuroscience and Human Behavior at UCLA. Dr. Hansen is an international leader in the field of social medicine and of the integration of rigorous social science into academic medicine, as well as into research on social determinants of health and health equity. Dr. Hansen popularized the term translational social science by launching UCLA Medical School's research theme in health equity and translational social science as its inaugural chair from 2020 to 2023. She's a celebrated author of 3 books, over 100 articles and chapters in leading clinical and social science journals. We are very grateful to both of our esteemed participants for taking the time from their busy schedules to share their knowledge and insights about the state of medicine today and the search for humanity in it. Just a few housekeeping notes before we begin. Today's program will run for approximately 1 hour, with the last segment reserved for your questions. If you would like to ask either of our speakers a question, please type it into the Q&A at the bottom of your Zoom screen. We have over 1,200 people registered today, so you can imagine there will be many questions, but we will do our best to get to as many as possible during the time allotted. Today's program is being recorded. You can view it tomorrow on our website, friendsofsemelinstitute.org. There you will find a calendar of upcoming events, past events, videos from past events, and information about the other programs the Friends of Semel supports, such as the Open Mind Film Festival for high school students, our Teen Advisory Council and the Gen Z Wellness Summit, and our Friends Research Scholar Program and Endowed Chair. And just one more thing. If you feel that our Open Mind series provides a valuable service to the community, we would greatly appreciate your support. There's a donation link on our website. Again, it's friendsofsemelinstitute.org. And there will also be a link on the thank you note that you will receive tomorrow. Now, please join me in giving a warm Zoom welcome to Dr. Jessi Gold and Dr. Helena Hansen. Thank you so much.
Thank you so much, Vicki, for such a generous introduction. Not overly generous for Jessi Gold, who is just an amazing writer, as well as someone who's contributed so much to our field and our understanding of how to take care of ourselves as well as others. The book is incredibly moving, Jessi. I just have to say, it's chock full of such evocative vignettes that have brought back to me vivid memories of my own work in many different places in my career. So I'm eager to delve in. And I wonder if we could start off with, how did this book come about? How was the idea for this book born? And then how did you actually end up writing it?
Thanks for asking, and thank everybody for coming and for having me and wanting to talk about this topic. You know, I didn't have like an aha moment, you should write a book. I had more of like a self-discovery moment that led me to realize other people were probably dealing with the same thing. And so in the middle of the pandemic, I was a psychiatrist taking care of healthcare workers primarily. I had a lot of guilt about being behind a screen instead of at the front line, like all of the people I was taking care of. So in order, I think, to combat the guilt in some way, I took on more leadership around outreach and education, was doing a ton of like talks and trying to design a clinic and trying to come up with a plan to like support everybody. And in that context, really wasn't paying attention to myself at all and burned out pretty badly, but didn't even identify it as that. And I think, you know, for me to be a person who is running around saying, this is what burnout is, this is how you take care of it, and also at the same time not paying enough attention to myself to even name it like that in myself, made me realize that a lot of people probably deal with that. You know, I think also sort of a secondary goal is I think it's important for me to have healthcare workers have their stories be seen and heard. I think predominantly in the pandemic, we saw that like there was a lot more popular press articles written about healthcare workers and their struggles, but I think it kind of teetered off just like it was at the beginning, and we're supposed to just kind of be fine now. And I think, you know, giving voice to the people that I take care of, the people that I work with, the people that I call friends, you know, humanizing them to themselves, but also I think to everybody who sees them was also sort of a bit, you know, a big motivation for me.
Yeah, so well said. So I think you started to touch on this, but I was wondering what you hope this book is going to do in the world and with whom. Like what would be your highest aspirations for this book and the set of stories that you tell through it?
I hope it starts conversations, because like conversations like this, honestly, but you know, for me, in so many ways, like as a person who gives lectures on wellness, it's an immediate turn off to people. Like they get mad, they get frustrated, they feel like you're not actually fixing the problem. They're just sending you to give them some information that they don't want to listen to. And I think I've learned how to navigate that as a lecturer, but I think in so many senses, like we wouldn't pick up a book like this because you'd be like, ugh, they're just going to talk to me about taking care of myself again, and I'm not going to like it. And so by using stories, by using my story, I hope to make it more accessible in a way that like lets people into some of the data, lets people into the conversation without like immediately avoiding it. I hope that it then, you know, you learn, you see yourself, you feel understood in some capacity. Maybe you learn some self-care because there are tools in there. It's just not like when you have burnout, you do this. And then, you know, you take that with you to your institution and start a conversation. And, you know, you and I both really think a lot about culture. And I know we'll talk about that some, but I think stories is like, you know, understanding what it's actually like for the people experiencing it, taking that back with you, having more stories. I think it really can prompt change in a lot of ways, and it make it feel like a less helpless, just broken system that we live in and work in. And I think, you know, as much as it's for healthcare workers, because those are the patients that are mentioned, everyone sees a healthcare worker for something. But also, I think a lot of the themes resonate across workplaces. I think a lot of the things that we struggle with as perfectionism, overwork, burnout, like mental health stigma, a lot of those issues like cut across industry, schooling, cultural background, all of that. And so I would hope that even if like you're not interested in like the actual character because it feels like that's you, that you would go, oh, I've had something like that happen too. I don't have to be in healthcare for that. And maybe you would also feel seen and understood, and maybe do some self-care as a result from learning something.
Yeah, that's well put. And I really agree that the foundation for the book is just these beautiful narratives. There's just so many incredibly well-written vignettes of people that you've seen and experiences that you've had. And I'm thinking, of course, this is sucking me in as a healthcare practitioner. I can identify with just about every moment of self-description that you give. But at the same time, I'm thinking that it gives a window to people who may not be healthcare practitioners, but go to mental health practitioners and are very curious about, what is it like to be on the other side, and how much can I identify with people who choose this career, And so you accomplish so much through the storytelling, that kind of fundamental um, commitment of true writers to show instead of telling, right? I mean, the narrative just sucks you right in, and it's a very hard book to put down. I was wondering if you could give the listeners who haven't had a chance to read the book yet just a little flavor for the structure of the book and the way that you use the stories to build up to certain points or certain kinds of insights that you want to share with the reader. Do you feel comfortable
Yeah.
sharing a little bit of
Yeah, I
that?
can do that. I mean, I would also say that what you were saying about like understanding mental health and what we do is it also sort of like a secondary, if not tertiary, I guess, goal for me, which is people have a lot of beliefs about psychiatry, but they don't often like experience it. And one of the probably louder ones is that we just medicate people and don't care about them as humans. And I very much don't practice that way. Most of the people I know that are in the field don't practice that way. And I think seeing what goes on in my brain when I'm seeing patients, how I think about it, how it's not just like magic that we're just sitting there and saying things, like we actually think about what we're saying and why we're saying it. And I think that that might also make it feel like safer and also make it more understood. But so basically the book follows me and 4 patients through the first 6 months of the pandemic. I don't want to turn you off by it being a pandemic book. The pandemic is very much just like this big stressor that made a lot of things known that were already known, but worse. And it's also the time period that I had these realizations. So that's why it takes place then. It's kind of, it's separated in like chapters that are either me or a patient, and it kind of alternates as you go through time, and you can see each person comes back about 3 times, and you see me go to therapy in there too. And they're composite patients, meaning they're not like one person specifically, but they're based on patients that I've had, a couple patients that I've had, plus some interviews I did with healthcare workers, just to kind of get more meat into some of their questions that I had. But we have, you follow a resident, somebody who's in training, who is newly diagnosed with obsessive compulsive disorder. You follow a pre-med student who has test taking anxiety. You follow an ER doctor who is just like numb and doesn't know why. And the last one is a nurse who's pregnant and is experiencing a bit of postpartum, and it becomes more like PTSD. And, I think through conversations, you can see where diagnoses come from, where some of the treatment thought processes come from, where some of the tool suggestions come from. But also, I think in using the stories to describe different points in time of training for different groups, it shows the different barriers over time. So, when you're a pre-med, what you're experiencing and thinking about might be different than what you experience as a resident, but you're still, that person became that person, which then becomes the other person. And so it all kind of compounds in like the attending patient who is numb because she already had all those other experiences before. And so the different time periods allowed for telling of the particular struggles you might face in those phases, like different phases, to identify them for people, because sometimes they are different. Like a resident might have more difficulty calling out for coverage, might be feeling more like a burden than some of us do as we get older, even though it's still very much like that. It was really important to me too to have a pre-med, because I think a lot of the data kind of implies that we go to med school and med school's the problem. And I think that there's a component of that that's true, but I did my entire master's thesis on pre-med as a culture. Pre-med wasn't fun for me. It's what sparked my interest in observing this and asking questions around this. So that wasn't like a typical just super fun time period. So I don't think we didn't have struggles then, so it was important to me to start there. It was also really important to have a nurse. I think I could go into all of the people in healthcare that make up our little village, because I've seen people who clean the hospital, I've seen greeters, but for simplicity's sake and trying not to make it too confusing with training and stuff, we interact a lot with nurses, and they have a lot of roles in our training that we probably don't talk about enough. And then I don't think that they necessarily talk about their mental health enough, but I've seen nurses in situations that, with patients or angry people or whatever you want to say, where you can tell how their job could affect them and does affect them. So I did want to make sure that I had a nurse included as well.
Well, you're raising so many other important points that I want to delve into, including the fact that this is also a really astute study of the culture of medicine and mental health care in particular. One of the things that you do so effectively is you use yourself, right? And one of the explorations that you dive into is disclosure among people who are mental health practitioners and what a taboo it is. It's interesting because we're trained. One of the sources of this idea that we shouldn't disclose in psychiatry comes from Freud, right? We're supposed to sit behind really a veil and not talk as much as possible and not reveal ourselves, definitely not reveal our own histories. And there's a holdover from that in current practice. But then in medicine, as you point out, in general, surgeons, internists, in general in medicine, we're trained that we're not supposed to, number one, show our emotion. That makes us an incompetent physician. On some level, we're not supposed to have emotion. There's some really, really evocative narratives and vignettes in the book around that, around the real taboo and punishment that comes around showing emotion as a physician. But yet what you're doing in this book is revealing yourself. You start off with a really poignant self-revelatory moment of a huge mistake that you felt that you made in your practice. And you end the book on the note of self-disclosure and your decisions to disclose a different concept and what that meant for you. So I wonder if you could talk some about that aspect of medical culture and psychiatric culture and the journey that you've been on around that and what you have seen as the impact of the level of self-disclosure that you've provided in the book.
Yeah, it's a good question. And I would also be curious, what you saw modeled, because I feel like maybe we're a little better, but maybe not at all. And so I would be curious in some capacity, what that was like for you. But I think, I've always been a pretty, authenticity is a core value of mine. Being who I am, showing up in spaces as I am has always been really important to me. But when you go to school that you earn, it's very competitive, you had to do a lot to get there. You go, well, do I have to be this way that they tell me to be to keep going and do well and be supported? And it's kind of yes, because in so many ways, when I would say something that I, over relating to a patient in some way or nursing in some way, I would get pretty negative feedback in things that were written about me when I was on clinicals. And it made me really upset, and it made me shut down a bit and go, well, to be successful, I can't be as me as I want to be. And maybe the way that we get through this and the way that this job doesn't affect me is to just be emotionless in some capacity, because it seems to be working for other people and nobody else seems to be talking about it. And, I carried that with me into psychiatry residency. I mean, psychiatry is a little better about asking you how things are making you feel like a patient or what the circumstances like, but you know, when we would watch ourselves do therapy, it's not like anyone was modeling self-disclosure in a psychotherapeutic setting in a way where we'd go, oh, like that's such a cool way to use that. It was just, don't put pictures up, don't talk about yourself, try to make sure you're like asking questions and sticking with the patient. And so it kind of, as much as it's a little more of an emotional field, it didn't like completely reverse it for me, right? Like it wasn't like, oh, all of a sudden this is allowed and I picked the right field for me and the end. But I kept kind of like testing it where I could, writing narrative where I could. You know, the very first time that I really wrote something that I got feedback on was a piece I wrote about something that happened to me in medical school. There's a bit about it in the book, where like a patient, like I got called into a trauma case and was basically, for lack of a better summary, tricked into doing cardiac massage on a person who was already dead. Like I had to, like, it was a very complicated, messy situation, but they called me in as a med student. I hadn't really been following enough because I couldn't even see because I'm short. And, you know, it was pretty clear after I was really panicked that somehow me never doing this before was going to kill somebody. Like the way the anesthesiologist communicated with the surgeon, it was pretty clear that like they were just giving me some time to play around, which, you know, in so many ways is bad about patient care, but it was also just like I didn't even like know what to do with that. The other med student was jealous that everybody else was like proud of themselves for teaching me that way. And I had a lot of feelings and I couldn't like express them because no one else was. And so I took to writing for that. And it was really like the first time that I had written something that then was in a medical journal where I could educate based on my experience and people cared. Like I could tell you something about something that happened to me and it made you think about training differently, or it made you think about teaching differently, or why we do certain things. And I realized so much in that, just the power of like narrative to teach and not even self-disclosure, like more publicly or in a room with a patient. And so I sort of like exposed like my own comfort level through writing about like saying a little bit more and then seeing what happens and how I felt and what the reactions were. Social media made that a little bit easier because I started talking about like going to therapy and stuff on social media, well aware that my patients could read it, but not like talking too much about it. And I think I have over time realized that the things that make me really good at what I do are because I am authentic, and I had to sort of refine that through becoming more comfortable with self-disclosure again, becoming more comfortable being myself in a setting that didn't really feel like I belonged. And I think being able to tell my story, being able to tell our stories makes you feel less alone. And I think I've felt like in telling stories to trainees and stuff that it has brought me closer to them because they feel like I'm not just this person who they don't understand. And I feel similarly with patients. I don't over self-disclose in a one-on-one setting. I think about it pretty mindfully, but if there's a reason to use it or they bring in something that I write and ask me about it, I will. And I think that it can spark really good conversation and is a really important tool. And I wish we learned how to use it, honestly, because I think I've kind of learned trial by fire or deciding that it's relevant. And it would have been really cool to learn that in training, to be honest.
So on that note, and this, I think this is also a culture of medicine moment, right? And you write and speak powerfully on vulnerability. Through your storytelling, you're showing how being vulnerable and making accessible things that you're not necessarily proud of, that you may feel ashamed of, emotions that don't typically get brought in by the practitioner into the room. You know, even by starting off with a mistake that you felt just horrible about, a description of that, you're making yourself vulnerable. And then you describe in great detail how that's something that's not only discouraged, but punished in medicine. And so I wonder if you could take a little bit of time to talk about the uses of the productive uses of vulnerability in healthcare and mental health care, and what would that look like to change the culture around that, around not only disclosing things, but making oneself vulnerable in the workplace, in the encounters with patients?
Yeah, I mean, vulnerability inherently by definition is scary. It's like exposure and risk, and all of the words that are used to define it make you feel scared to do it to begin with, to be honest. But I think there's so much power in it that I wish that we did it more, or that people felt more comfortable doing it. I think I have decided through my own reflection, through my own therapy, where my lines and where my comfort is with storytelling. I don't believe that anybody owes anybody their story. I think that there are places like social media that make you think like you should tell everything, but I think you can still decide when and who and why, and that's your story to tell. But for me, because I am a healthcare worker who sees healthcare workers, I really thought it was important to figure out what all my barriers were around that and why I hesitated and where that came from. And if I could figure that out, I could talk about that openly, and I could also maybe help people be more vulnerable themselves, and maybe not to the degree that I am. Maybe you don't want to talk about being on meds or going to therapy, but maybe you want to just say, like, that was hard. I think today I heard yet another story of someone who learned about emotions through watching a code. And when somebody, there's a lot of chaos going on and people are doing CPR, and maybe the person lives, maybe the person dies, but inherently nobody makes a reaction at all. Like, no change in face, no acknowledgement that that was challenging, no checking in on the trainee about what that was like. And, almost everyone I talked to for extra interviews told me that's where they learned about feelings, like watching their supervisors have none. And they were like, well, I guess we just do this and don't have feelings, right? And I heard another one of those stories today, and it really reminded me that, like, we can be vulnerable without being so vulnerable. Like, I have decided to be very vulnerable for my own decisions and reasons, but I think, we could pause and say, what was that like for you? Or how this could have, is this the first time you've ever seen a code? What did it feel like? Right? Like, we don't have to go right into eat lunch or the next patient. We can pause briefly and give people space that they need to realize that, like, that was a hard experience and what they saw was challenging. And I think there's vulnerability in that, and like simple acts of it can really change the culture, because if you saw your supervisor do it, you'll know it's okay to do when you're a supervisor, and it sort of has like domino effects in that setting, which is pretty powerful, because we really do learn from what we see. They use the word hidden curriculum, but they usually mean like skills. Like, you learn like how to do something by seeing the way that someone acts with a patient, because you can't really learn that in a book. But you also learn how to feel in the workplace by witnessing it. You learn how to react to somebody dying. You learn how to talk to each other, and all those things I think could improve if we just like slightly increased our comfort level with saying the stuff out loud that we're thinking.
Wow, so well put. And I wonder if you could say a little bit more about what would we gain? How would things be different if we did take those moments to make space for people to express their feelings, or to acknowledge that things are difficult, or, the kinds of interventions you're describing, which seem intuitively like they make a lot of sense, but they actually don't happen in mainstream clinical practice. What
Yeah,
what
they
what would be different in a world like that?
I think that we would feel more cared about as people. I think that there are a lot of systems at play that we don't have a ton of control over, but that dictate how we function. I think this happens in all workplaces, but I'm sure people know that healthcare is like some of the profit mechanisms, some of insurance, some of like policies that go on, right? There's a lot of these things that interact with how we do our job that are these big megalithic, like, feel like you could never change them things. And I think that makes a lot of people frustrated, and a lot of people feel hopeless in a lot of ways in the workplace, because they are like, this isn't how I want to be doing things. I don't feel good doing it this way, but maybe this is how it's going to be perpetually. How do I fit here? And you fit there if everyone else also agrees with you that the system is horrible and you're not alone. And they also can talk you through how they're dealing with it, and you can feel cared for in that setting, and you feel supported, and you can find little moments of win in a broken system where you can still be a good patient advocate, where you can still practice the way you want to. And I think it maybe will keep more people in medicine. I think that's one thing. I think that we'd have healthier teams because we would check in on each other and ourselves. I think, in so many ways, I would hope that we would not all be waiting until we were quite sick to check on like ourselves as well. Like most of the people who show up in my office, they say something like, I didn't make a mistake yet. Like I didn't hurt someone yet. And that's like their bar for whether they're allowed to ask for help. And we have a high suicide rate in healthcare workers too. And so, we either hide it and hide it and hide it, or we wait and wait and wait until we can't anymore. And I think both of those options are not what I would want for my colleagues and my patients. And I would hope that if you felt like there was someone you could tell the truth to because they were telling the truth to you, maybe you would notice your own distress earlier. Maybe you would feel more comfortable talking about it, and maybe we wouldn't be losing people in healthcare.
So that makes so much sense. And yet you mentioned systems and broken healthcare system. And as an anthropologist, I know that you think at that systemic level about, well, what are the barriers to working that way? And so I wonder if you could talk a little bit about what would be necessary to create that kind of environment. And do you think that that kind of environment could also lead to further systemic change in our healthcare system and beyond? What would that
I
look
would
like?
also be curious about your answer to this question, but I'll answer it first.
Fair.
I think there are a lot of systems at play that need to be changed in this setting. So I think that there's a way that we in the cost model and the insurance model are not thought of as people as much, like the time we're given for patients, the way that our time is valued, like how much time we have to spend on paperwork versus with a person. I think that if you have a awareness of like the person that's doing the job and not just a robot could do this job, you might have a better sense of creating systems of seeing patients that feel better for both patients and providers. Like currently, I think neither really like the way healthcare is run. Like, I mean, patients are mad all the time, and we're mad too, and we're just all mad together. And I don't think that's particularly helpful. And so I think that there's like when you have a recognition of the what would actually be good for people, and you care about that could change things. I think on the system level, we beyond the money aspect, there's a lot of time spent like documenting and doing notes, and a lot of complaints about no time, no support to do the things that you want to do. I think, in so many ways we talk about like, here we provided you access to care, and people say, well, I have no time and no support and no money. Like, how am I going to go get treatment? Right. And so stigma obviously is one thing, and we have a lot of that, but just like everybody trying to navigate the mental health system, if you're working night shifts or something, like when are you supposed to see a therapist? And if there's stigma and you go to something once a week, what else is there? Right. And so I think there are all these barriers that exist, like just in how work is structured and training is structured. And like, I get very lost in what it would look like to redo it, because I think we'd have to like basically blow up the whole thing and start from scratch. but I do think that, being more mindful of like how we care about each other, maybe we wouldn't show up for work like really sick, and we wouldn't feel guilty for taking time off, and we would feel more able to step in to help people because they helped us. And like, there's just more of a less frustrated culture that's just like mad at the man all the time. I don't know. What do you think about that?
Well, I think one point that you're making beautifully is that when we work on the things that are more or less within our orbit of control, it has these ripple effects. So taking that moment to check in on each other and ourselves, and thinking about and talking about the ways that the systems we're embedded in make that difficult, and the impact that it has on us. Like, it builds awareness. And I know, I'll just speak from personal experience. I think we're in a moment of just widespread disenchantment, feeling of disempowerment among people who practice clinically. A lot of despair, I would say, among people who are doing clinical work right now. Many of us feel trapped in this really huge oppressive machine in which healthcare decisions aren't dictated by the practitioner or by good medical practice. They're dictated by larger economic kind of business logics. And so increasingly, practicing healthcare feels like a really, really disempowered position to be in. And many of my colleagues talk about moral injury, right? That we go into medicine hoping that we can be of service, hoping that we can help improve outcomes for people. And then we find ourselves trapped in a system that doesn't give enough degrees of freedom, and in fact, often compels us to do things that we know are not good for our patients' health, such as boot them in and out of sessions really fast. Huge delays in attention for people who are in acute crisis. And then in psychiatry, there are all different kinds of permutations of things that we force people into that we know aren't good for their mental health. The conditions of treatment often in our hospitals. We're in Los Angeles, where we're very close to the largest single provider of public mental health services in the country, which is the LA County Jail. What does that say about us as a society, that people are ending up in jail before they get mental health care? And we're part of that. And so that moral injury thing is really strong right now. And what you're describing is a way that we can begin in our orbit to start to push back against that, and to start to feel empowered, that we're not only empowering ourselves, but each other, in that kind of acknowledgement that we too have needs. And if we can start to address our own needs, we can start to better address our patients' needs. And maybe then we have the stamina and the energy to start looking systemically at how can we advocate and work to improve the system, because clearly the system is really broken, as you said. So that's what comes to mind for me. But I wonder if you would have
being in the rooms like where the decisions are made is also important, right? Like, I now have a system role, and when I was younger, I would just be like, this is the worst, like, let me fix this thing, and I would spend like hours trying to fix a form so the form would be better for people and not take time, right? And none of my friends understood it, and they were just like, just fill out the bad form, that's the way the form is, right? And I was like, no, but it could be better, right? And some people's brains work like that, and some people's brains like that work like that need to then be put in charge of trying to fix stuff. And I think the more of us that are in the room, the more likely that it can change, because I think so many times I'm in rooms, like I do a lot of traditional academics, not even just healthcare, where people don't think about how things impact wellness, not because they're like don't want to, but because they never had to, or it wasn't how they were trained. Like they came up through a purely education route, or student affairs route, or housing, or right, like these other aspects of a university that they're not spending all of their time swimming in the same things that I am. And so I feel like, when we have the energy, because we feel like we can, or we might, like some of us could also be leaders in the area, to be able to say like I hear what you're saying, there's profit in trying to be aware of the people who have working for you too, because you don't want errors, you get sued for that. You don't want everyone to leave, that costs you money. You don't want them to sit in their job unproductive and burnt out, that costs you money. Like, as much as I don't like to make monetary arguments, there are monetary arguments for why you should care about your workforce. And they feel intangible to people, I think, because it's less clear, even like dealing with mental health during COVID versus dealing with COVID during COVID felt intangible in so many ways. Like we see the repercussions now. You ask any healthcare worker, they saw the repercussions too, but it
Right.
was much more obvious to try to stop the active like pandemic than it was to think about what the delayed pandemic would be, right? And so I think being in the rooms matters as much as it's frustrating. And then I tell people like, I'll do that. You fix like you and your team and the things you can control in a serenity prayer way, because if you think all day about all of the systems, I don't honestly know how you like, I don't think you can even mentally survive the job, because I think about college students like this a lot too. They care about the world and they care about the world really deeply, and they play on TikTok and they see stuff and then they see more stuff and it makes them sad because they want to fix this stuff, and the stuff is going to take a lot of people to fix. And when you think about all of that, you can get in like a pretty negative spiral. Like I've had times as a psychiatrist where I'm like I can't medicate systems away, right? Like the reason the jail is the primary provider is something that like you will see coming in and out of your ERs too as a psychiatrist, where you're just like, we're not doing this right, but and I can't fix that with a medicine, and the tool I am given to fix that is therapy and medicine, right? And so I think in so many ways, like if you are paying attention, that it can be a lot, like just constant bombardment of broken systems. And like we have to have some like serenity prayer acceptance around some of it, to be like, where can I put my energy that I could maybe do something that'll feel effective and won't feel like I'm constantly screaming into a void. I don't know. You do a lot in health disparities. I can't even think, like my brain is just like, I mean, I think in so many ways that has so many like similarities, or is kind of what I'm thinking about too, is just like all of the systems of people's lives at play too, that come into then showing up in healthcare.
Yes, absolutely. You raised a couple of threads that I'd love to delve a little bit more into. One is that there are these costs to our society that could even be translated into and also our patients and our healthcare workers and systems that aren't factored into the really narrow financial model that our healthcare organizations are driven by. And so that's one thing. And then the other thing you're talking about, I think, is how do we balance that awareness of what we're up against against what we can do in our day-to-day work. And definitely we're seeing record rates of dropout of clinical practice. Already before COVID, that was happening, particularly in mental health care, right? People are dropping out of clinical practice and doing other things out of the kind of disillusionment and sense of disempowerment. COVID came along and really accelerated that. And so we're seeing that we're in the middle of that. And when people who are dropping out of practice are asked in surveys, national surveys, about why, they bring up the systemic barriers to providing good care and the fact that the locus of control is out of their hands. The things they know they need to do for patients, they can't do. Their hands are tied. So that's that moral injury, I think, moment. On the other hand, I have colleagues who do research on what impact it has to give practitioners, particularly residents, physicians in training, an opportunity to work in a better system and in a better way that addresses the systemic barriers. And like partnering with community organizations to do innovative approaches, meeting people where they are, and delivering care in a way that really resonates with the patient populations. Or, we're partnering with a housing agency to make sure that when patients are unstably housed, that they are they get accelerated access to housing and wraparound services in addition to medical care. The studies of the impact of doing that have shown that when people get a glimpse of what it looks like to be able to address those needs and do their care effectively, that pushes back, that reverses the disillusionment that progresses among clinical practitioners through their training and practice. It actually makes them more optimistic and reinvest them in clinical care. And so there is this balance there. That's the work that I've been doing under the rubric of structural competency, that if we as practitioners educate ourselves not only about the systemic barriers, but how we can partner with community organizations or with housing agencies and other non-health sector agencies, or even policymakers, and advocate for policy change, that keeps us going, that reinvests us in our work as clinical practitioners. So I think you're right that all of this does happen. We get really overwhelmed. On the other hand, there are things that we could be doing locally that have kind of a global vision, but they're local, smaller interventions that give us a window on what it could look like to practice clinically the right way, and meet people's needs.
I think and so many of my patients will not do some of that stuff because they're so burnt out and overwhelmed, but that stuff would be the life-giving stuff, right? Like you look at your calendar and you say, no, I can't take a mentee. I can't even breathe in my current structure, but all you're left with is the stuff that's burning you out, and none of the stuff that gives you energy back. So like volunteering maybe would make you feel more connected to the community in like a one-on-one kind of way, or actually being able to see and help the systems. Showing up in an advocacy policy way does help me in that way too, like feel like, okay, I can't fix that for everyone right now, but maybe if I use my voice and what I know, I can be helpful. And that's like energy giving to me. Part of writing the book is the same thing, right? It gives me like a way to ground, to advocate for change if people ask me the right questions, right? And I think, or they want to have the conversations. And so I think like, all of us, no matter what field we're in, I think when we think about what we say no to, like I'm a big believer in saying no, don't get me wrong, it's something I have to work on, but I do think that we often say no to things that maybe we would have had benefit from because we're just afraid we don't have capacity. And like just kind of be mindful of that sometimes, because I think we say no to social events. We say no to going to the soccer game. We say, because we're just like, I can't do that, but it's not necessarily always just another thing. It might actually give you back what you're losing.
Such a great point, that the antidote to burnout is not always to do less. The antidote to burnout is to adjust what you're doing, right? To put more of the life-giving activities back in your life. And you also raised a question about inequalities and disparities. And I wanted to go there for just a moment, because your book does talk about that too. There are vignettes, for example, where you talk about race and bias and the impact that you imagine that has on the patient's experience that you're, confronting. You also raised the point about gender and suicide and self-harm, and women physicians in particular are at very high risk of suicide compared to the general population. So there's something there about power relationships and where we find ourselves in the healthcare system and in mental health care that I'd like you to explore a little bit more with us. Where does that fit in the model that you're giving us? And what does explain the high suicide rate among women? What have you learned from your patients who come from racialized, minoritized backgrounds?
I learned from my mentees from backgrounds that are different than mine as well. I mean, I will tell you, there's a composite patient that is a Black female, and I did not have as much about race as I do now, because my friend who's a Black psychiatrist read it and said, you're better than this. Like you just scooted through it because you're afraid to be the voice. But if I'm always the voice, that's not helpful. Like you have to use, like, this is a thing. You have to say it's a thing too. And she really pushed me, because honestly, like it wasn't necessarily coming from my editor's side either. They kind of were like, I don't know if you should be getting into all of that. Right. And I was like, but you can't ignore that. It's a part of the conversation if you show up in an ER and you're not being listened to, because that's what happens historically, or you have fear of being in the ER for other historical reasons. If mental health is viewed differently in the culture that you came from, that like asking for help at all is seen, very counter to your experience if you're expected to be a stoic person who can deal with everything because that's the cultural perception of a Black woman or something like that, right? So there are all these things that factor into how emotions are processed, how people are treated, how they feel in certain settings. And I think, knowing that is very important. And very important in our field in particular, but I think in all fields. There are not enough people that look like you that can take care of you. So the rest of us have to have some catching up to do to make you feel safe to see us until we get the workforce to look more like the population. And I think in so many ways, like, we're moving towards that. We care about that. We think about that, but we need to be talking about it more vocally. I mean, I think when we think about all of the ways that the system is interacting, we have to stand up for the groups that are not standing up for themselves in those contexts. Like, if it is harassment is contributing to burnout, we need to talk about it. If all of the people leaving or feeling the most marginalized are people of color, we have to talk about it. Like, we need to look at the data like that. We have to have conversations like that. We can't just like make a one size fits all system change either. Like, we have to look at how different groups are feeling in healthcare and as patients or as providers to really make change, I think, because there are different reasons you feel burnt out as the female person. I mean, I think one of the statistics I find most interesting is if you have a dual physician household in COVID, the women are more likely to cut their hours. The women were more likely to take care of the kids. The women and they literally went to the same job, right? But given the same job, they still took on all of the sort of like gendered women responsibilities. And that is like another job on top of their job. And they're more burnt out and they don't feel like they have a voice because they're not as many women, or the people that they're talking to don't understand, or they feel like they need to kind of suck it up to deal with it, to be the person who can make it through. And I think so many, and you can correct me if I'm wrong, but a lot of my like attending level people that I've known that have made it through are almost like numb to some of the things they fought through because they're like, we just had to deal, and if you don't get that, like, it's harder for you, just have to kind of deal to be the only. I don't know how to explain that, but I think in so many ways, like, sometimes that can lead to different interactions with like younger females and older females because of like how the culture has changed or shifted. But I'm just rambling.
That resonates. No, that resonates. Yeah. I mean, fewer degrees of freedom to be vulnerable too.
Yeah.
So thank you. I see Vicky is back online.
Vicky's like the universal sign of someone else has a question.
I want to just first, before we get to the questions, I want to thank you both so much. This was a fascinating discussion and you imparted so much valuable information to especially to the healthcare workers that are listening in today, and to us lay people as well. You gave us a look into the healthcare system, into psychiatry, into what you all have to deal with. And it's really, truly, the two of you give us a lot of hope because you're both so dedicated and so brilliant and have so much to give. And I hope that our healthcare system can adapt to some of the principles that you've talked about today, because I think it would be a vast, vast improvement for all of us. So
it's probably because we're both anthropologists.
That could very well be. You have so much in common. It was fun to write the introduction about you. Jessi, I want to thank you for writing this book. I think you've helped a lot of young people who are thinking about going into medicine and also medical students today. And I also want to congratulate you on being such an incredible promoter. You are all over social media, and I know you self-promoted this book and made it a national bestseller. So congratulations to you.
Thank you.
We have a few questions to get to, and one of our listeners has a terrific idea. And now I've lost his question. Just give me one. Oh, here. One effective way to disseminate the information in your book is to make a documentary or a series of programs based on it. Are there any plans in this direction? What a great idea. Go, Jessi.
I mean, nobody's
version. Yeah.
optioned it. You know, if this is the audience that has probably some connections. So I'm always game for that stuff. You know, I very much believe in like the different layers of storytelling. Like not everyone's going to read a book, but somebody might watch a TV show, and like people watch Grey's Anatomy and really care about us, but there's very rarely touches on how that impacts our mental health. And so I do think there is like space and room for these kind of stories. You know, someone's always welcome to option it. I would love to do something more that way, but you know, it's not my area of expertise by any means. So I would never say no, though.
All you Hollywood people that might be listening in today, here is your opportunity. We have a lot of comments. One, somebody asked if you could be their psychiatrist, both of you. And a lot of great comments about appreciating how you normalized mental health care. And I think that's so important. I have one question that I'd like to ask you both, because you went through this whole system. What made you choose psychiatry in the first place? Can I throw that out there?
You want me to answer first, or you want Helen? Okay.
Either.
Okay. So I went into med school not wanting to be a psychiatrist because my father's a psychiatrist. And I tried to not, for some reasons we could get into or you can read about because they're in the book. But, you know, I went in going, I like the brain, but I'm not going to do this. And I tried to do neurology. And literally every patient, I would want to like talk to them about their story and like not just their diagnosis or their treatment. Like I wanted to sit and I wanted to have time and I wanted to hear things. And that was like always what I kept going back to. And so even if I was like trying to fight it, or even if people made kind of offhand comments about psych, because it is a stigmatized field too, it's getting better, but sometimes people say, why go to med school for that? It felt like the place where people were spending time with patients still, where their like upbringing and stories were really important and you had time for that, where people were writing and people were doing all these other things, and they weren't just only seeing patients all the time. And they had like very diverse, like what their work life looked like, which was important to me. And like, additionally, I would just say it was also the few rotations in med school where like I felt like a human being. Like they asked about me, they saved me a seat, they labeled the seat, right? Like that seems really silly, but as a med student, like I was literally called med student most of the time, right? Like they just rotate you in and just assume you're another one, right? And so to have people know your name, to label a desk, like be seen as the person, not just like another person to do the work, like also made me go, oh, like this is better for me.
Thank you, Jessi. Helena?
You know, it's so funny, Jessi, you and I have a lot of things in common. And one of them is that I went into medicine absolutely dead set against psychiatry. Both of my parents are psychologists, and I grew up knowing I wanted no part of it, especially since they would often, you know, give their analysis of whatever I was going through in kind of this professional tone that I did not like. So I thought I was going to be an HIV specialist. I came of age in the late 80s, early 90s, around the height of AIDS activism, and was totally inspired by what I saw happening in communities that were really heavily affected by HIV at a moment when the government and the healthcare system were completely abandoning them. You know, it was a crisis definitely on the proportion of the COVID pandemic more recently. And when I try to explain to my students and my younger colleagues what it was like back then, those that were born after the peak of the AIDS epidemic, you know, I try to make analogies with COVID, but what I saw was the incredible bravery of people on the community level, who many of whom were themselves, you know, struggling with HIV infection, organizing and lobbying and getting major policy change and changing the way NIH distributes money and does scientific priority setting by getting representatives among community members to sit on advisory councils, and changing the way federal funding for healthcare is disseminated, the Ryan White Care Act, requiring community councils with people who are directly affected, who are HIV positive or from heavily affected communities, to sit on those boards. And so I was inspired by that, and I thought that meant HIV as my area of clinical expertise. And then when I actually started rotating on the wards, I found myself as an anthropologist also interested in interpreting people's behaviors and their social context and where they fit in the social system, always in conversation with the psychiatry attendings. It was always, the psychiatrist that I was talking to. And my husband pulled me aside and said, Helena, I think you might be a psychiatrist. Just face up to it. This is pulling you. This is drawing you in. And then many decades after growing up in Northern California during deinstitutionalization and having 3 out of 4 of my uncles go in and out of mental health care and ending up on the street or in jail, I realized I had totally blocked out the horror as a girl of coming to my grandparents' house where I grew up and seeing an ambulance or seeing a cop car and seeing my uncles being pulled around and seeing them in mental health distress. And I realized then, oh yeah, there's something really kind of fundamental to me and my childhood and my family that I'm also gravitating to mental health care. So there's something very deep there that I wasn't even aware of for decades. So that's me. That's how I ended up with this.
Well, we're all the better for having you both.
Thank you. Thank you. This has been so inspiring, Jessi.
Thank you.
I
so
am
much.
recommending this book to all of my friends and colleagues, many of whom are on the line and already have your book.
Hello, everybody. I saw it quickly and I just want to address this. Like, if you're a med student, I'm not telling you this to not go into the field. I'm telling you this to go in with your eyes open, right? Like, I want you to go in, like when I was in undergrad, somebody was like, it was very much all of this insurance taking over healthcare and people said, don't do it. And I just stubbornly ignored them and said they didn't know what they were talking about. We know what we're talking about. We're not always right. So listening, trying to figure out how to learn skills and how to be yourself within the context of the system, being like very mindful of what it looks like before you say what you want to do, questioning it is healthy. How you support somebody who's a loved one that's a healthcare worker. I saw that too. Ask them how they're doing and give them space to tell you the answer. Like, the reason the title is what it is we don't do it. And we say fine, we say okay, we say exhausted. There's a lot more there. So, give them the space to talk about them, give them the space to talk about how work affects them, like care, reach out, that sort of thing. Say thank you if you go to a healthcare worker, and we don't get that very often, so those are my tips for people thinking about the path and people who are trying to support others in the path. I saw those questions and I just didn't want to blow them off because I think, like, I'm not trying to scare people away and I'm not trying to make you think that your loved one is like perpetually depressed, but there are ways that you can support your loved one and you can still go into this field. And if you at all have emotions, I'd like you to go into this field. It matters.
Well, thank you. Thank you for getting to those couple of questions too, Jessi. I want to thank you both. This was just an enlightening conversation. And I know so many lay people are fascinated by psychiatry and want to get to know you better, and you gave us that opportunity. So thank you. And I want to thank everybody that tuned in today. Thank you for the privilege of your time, and we hope to see you at many more Open Mind programs. Visit our website, friendsofsemelinstitute.org. You'll see a schedule there, every upcoming program. So thank you again. Stay safe, stay well, and we'll see you soon.
Thank
Bye.
you.
Bye.
Thank you.